بس هذا هو أبدي أحكي له. ها؟
إيه؟
Yes. Bone and joint infections. Septic arthritis is the most destructive joint disease, so it is a medical emergency. Septic arthritis is divided into two groups of arthritis. One, nongonococcal septic arthritis. Usually it is seen in all diseased patients. Staphylococcus aureus is the most common causative agent, infective agent. The second group of arthritis is gonococcal septic arthritis. Usually it is seen in patients of less than 40 years of age. These patients are sexually active patients and healthy. Keep in your mind that normal joint is very resistant to infections. So we shall start with the first group, which is the nongonococcal septic arthritis. The nongonococcal bacterial arthritis, most affected by Staphylococcus aureus. 90% are monoarthritis, single joint involvement, mostly knee joint, left hip, wrist, elbow and shoulder joints. Hide here.
إيه؟
Nongonococcal septic arthritis, most patients are affected by Staphylococcus aureus. 90% are monoarthritis, single joint involvement, mostly knee joint, less hip, wrist, shoulder and elbows, while small joints of the hands and feet might be affected by direct inoculation or by a bite of a cat or a dog. There are an underlying host pre-existing disposition, so it might be seen in disease sick or old patients, as patients with rheumatoid arthritis, diabetic patients, patients with steroid therapy, patients on immunosuppressive therapies, hemodialytic patients, alcoholism and IV drug abusers. Prosthetic joints in the knees and hips also might be affected. So, as we have just said, it is an acute monoarthritis, presented as painful joint. The joint is swollen. There will be decreased range of movements. There will be muscle spasm, fever. The inflamed, swollen joint is usually evident on examination. Except in the deeply situated joints, as hip, shoulder, or sacroiliac joints. In those joints, the clinical features is not very obvious. Bursitis, cellulitis, and osteomyelitis should be distinguished from septic arthritis by their greater range of motion. A focus of extra-articular infection as boil, pneumonia should be looked for. Also for pyelonephritis. Investigations. The most important investigation is the synovial fluid aspiration and gram stain and culture examination. So one should aspirate the joint and send the synovial fluid for culture before giving antibiotic. Yes. The other investigations are the ESR, CRP, which are usually elevated. X-ray of the joint shows tissue swelling and widening of joint space. As regarding the synovial fluid examination, the synovial fluid is examined for 3C. 1. Cells count, 2. Crystals, and 3 for culture. 3C letter. Synovial fluid examination is diagnostic in septic arthritis and crystal arthritis. Generally speaking, synovial fluid examination results are divided into 4 groups. 1. Normal synovial fluid. 2. Non-inflammatory synovial fluid, as in OI of the knee. 3. Inflammatory synovial fluid, it is seen in rheumatoid and Reiter's and other inflammatory joint disease. The 4th group of synovial fluid is the septic synovial fluid. Here we see the synovial fluid usually is opaque, turbid, and with variable viscosity. White C count is more than 50,000 per cubic millimeter, and polymorphonuclear leukocytes presented as more than 90%. Now, management of nongonococcal septic arthritis. Davidson, edition 23rd edition, page 1104, 1104. As just we have said, septic arthritis is an emergency. So the patient should be admitted to hospital. One should aspirate the joint. Synovial fluid is sent for gram stain and for culture. Blood is sent for culture, full blood count, CRP and ESR, and renal function test. Other samples as sputum, urine, etc. also we might need them. Emergency treatments are the following. 1. IV antibiotics and IV. Flucloxacillin 2 gram 6 hourly by IV route. If the patient is penicillin allergic, give clindamycin 450 to 600 milligram 6 hourly. If we have risk of gram-negative sepsis, as in patients with recurrent UTI and elderly, add cephalosporin. In addition to antibiotic, one should do serial needle aspiration. Serial needle aspiration of the affected joint 1 to 3 times daily till a dryness of that joint. Also, you should add analgesia, and other is the early active rehabilitation from first day. Early passive, then active movements. IV antibiotics are continued for 2 to 3 weeks, to be followed by oral antibiotics for another 6 weeks. For infected prosthetic joint, the joint should be removed. Removal of the prosthetic is required for eradication of the infection by orthopedic surgeon and theater. No. This is the gonococcal joint disease. Here the presentation is a gonococcal joint disease presented as migratory arthritis and tenosynovitis with or without skin lesion in a sexually active adult before the age of 40. Here you should suspect the gonococcal joint disease. It is caused by Neisseria gonorrhoeae, which differ from non-gonococcal septic arthritis. Female are affected more than male. Positive extra-articular GC culture can help to confirm the diagnosis from genitourinary tract, throat, and rectum, as gram stain and culture from the synovial fluid of affected joint are usually negative. Resistance to penicillin is rising nowadays, so one should use third generation cephalosporin as an initial treatment. Usually oral therapy is enough. Yes, we have finished the septic arthritis. Now another topic is another topic is viral arthritis. Most viral arthritis are self-limiting. The usual presentation is with acute polyarthritis, fever, and rash. Treatment is asymptomatic. Another topic is mycobacterial arthritis, TB arthritis. It accounts for 1% of all TB cases and 10% of extrapulmonary TB cases. So TB arthritis. The most common presentation is a chronic monoarthritis involving large weight-bearing joints, particularly knees, hips, ankles, and dorso-lumbar spine. The fluid from the knees or the ankles will reveal the following findings. White pieces average are about 20,000 per cubic millimeter. 50% are neutrophils. Acid-fast bacilli are positive in only 1/3 of cases. Biopsy from synovial tissue is positive in 90% of cases. TB involvement of the spine is called Pott's disease. Pott's disease, TB spine, is the most common bony TB. Started in lower dorsal or upper lumbar spine. Infection started as TB discitis, then involved the anterior vertebral bodies leading to angulation, wedging of vertebral bodies, leading later on to kyphosis, gibbous, qambura. Paravertebral psoas cold abscess is common, which might descend to inguinal region. Pose disease might be presented as back pain. There might be neurological complications if there is spinal or coda equina compression. Pose disease is differentiated from malignant metastasis in the spine, in which it is started in the vertebral bodies, then leading to vertebral collapse, while in TB spine it is started as discitis and then involved the bones. The treatment of TB spine, of tuberculosis, should be continued for 6 to 9 months by quadri or triple therapies: rifadin, rifampicin, INH, ethambutol, streptomycin.